You can allow the participants. I don't see the participants. Balaji, welcoming you on behalf of MCure Pharmaceuticals for this afternoon's webinar. A very special occasion for us to meet because this has been a traditional presentation. After every Croi, we have this presentation on the updates from Croi. And who else other than Dr. N. Kumaraswamy, the Chief and Director of VHS Infectious Disease, will be the presenter for this evening's webinar. And to introduce him, I have the pleasure of bringing on Dr. Ketan Kulkarni, the Deputy GM Medical Affairs of MCure Pharmaceuticals. A few announcements is that as we go along this evening, people are welcome to, participants are welcome to post their questions in the chat box, and doctor will be pleased to take these questions at the end of his presentation. Well then, over to Dr. Ketan.
Thank you, Mr. Balaji, and a very good afternoon, very good evening to everyone from India, from Pune. I'm Dr. Ketan Kulkarni from the Medical Services team at MCure Pharmaceuticals Limited. On behalf of everyone from MCure, I welcome you all for this very exciting webinar. So MCure is a globally integrated company, and it is also a research-driven company with around 500 scientists working round the clock. MCure has around 8 world-class facilities and 1 facility in US. So this is an initiative from MCure Pharmaceuticals in order to disseminate the latest happenings in the field of HIV through a series of webinars to eminent experts and renowned faculty from various segments. Okay, and this webinar provides an opportunity to update themselves on the recent advances in the field of HIV, and we are proud to be associated with all of you through this webinar program. So this webinar program is updates from Croi 2024, and the speaker is the eminent Dr. N. Kumaraswamy, who is joining from Chennai, India. To introduce Dr. Kumaraswamy, sir. Sir is the Chief and Director of VHS Infectious Disease Medical Center, Chennai, India. He's a director at the Chennai Antiviral Research and Treatment Clinical Research Site, which conducts therapeutics and biomedical prevention clinical trials in infectious diseases. He is the clinical investigator for various research projects from Brown University, University of California, San Diego, Harvard University, University of Washington at Seattle, University of Colorado, also University of South Wales, Australia, King's College, UK, University of Bern in Switzerland, and also for WHO, DBT, and ICMR of India. He is a clinician and a researcher in infectious diseases with 25 years of experience and has published more than 450 manuscripts in peer-reviewed medical journals. He is the advisor and expert panel member for WHO ARV Treatment Guidelines Committee and a chief advisor to the Clinton Health Access Initiative. So I welcome Dr. Kumar Swamy sir, and I now hand over the session to him. Over to you, sir. Thank you.
Sure. Thank you for the kind introduction. And good evening, everyone. So today I'm going to speak to you on the antiretroviral treatment updates from one of the recently concluded conference called Croi. Can I get my slides here to give me an... Okay. Can you see my slides?
Yes, sir.
Yes, doctor. Please go
ahead. Okay, right. So as I said, I'm going to speak to you today about the antiretroviral therapy update following a conference called Croi, which some of you have attended in the past, or probably they would have attended this time, either in person or virtually. And this conference every year happens in the United States. And this year happened in the city of Denver in Colorado. And in this conference, all the key cutting-edge research findings in antiretroviral therapeutics are presented. And also in this Croi conference, not only on treatment, but also some of those biomedical prevention tools were also being presented. And other than this, there were presentations on key findings on certain opportunistic infection neurodiagnosis and treatment, particularly in TB. And there were discussions in hepatitis, especially about some of the newer therapies in hepatitis B, in monkeypox, and also some of the newer emerging viral diseases, including some of the STIs. I think in today's this webinar, I'm going to just stick to only on antiretroviral treatment update, because of the time concerns. But on the other hand, there are a lot of other newer therapeutic modalities and other opportunistic infections and co-infections were also being discussed. So today in my talk, in the next 30 or 35 minutes, I'll just give you some of the new findings which have been presented, how it can maybe influence some of your practice or some of the guidelines. I'll talk to you briefly about integrase resistance, which we all know that you use the dolutegravir as a preferred therapy as first line, second line, third line. We have not seen much resistance in the past, but there were presentations which you will see in some of the data. And you might keep hearing these long-acting antivirals the last 3 to 4 years, and there were very interesting findings, how it will make your practice. I'll walk you through that. And also very interesting presentations on long-acting oral antivirals. Instead of taking every day, can we take weekly? I will share some of those findings, which will be very interesting, might influence your practice later. And also some of the newer outputs on some of the antibodies, on broadly neutralizing antibodies, along with the ARVs, still in pipeline. And I'll show some data, just to have it in your mind that there is something coming up. And I'll wind up, I'm not going to talk much about the comorbidities just for want of time, but two important, comorbid conditions. One data from the RIPRE, which I was been involved in that particular clinical trial, and another on slim liver disease, which again is a major problem in all of our practice. I'll just quickly browse that, but on the other hand, I'll focus more of my talk on these antiretrovirals. So this is a large meta-analysis of all the phase 3 clinical trials in antiretroviral treatment naive patients where they have used dolutegravir containing therapy. There are various trials that happened in the last 10 years. The first one started way back in 2013, Spring 2, which is one of the trials which helped to register this product and get a US FDA approval. And since then, there are several studies that have been done, including up to Gemini 2 a couple of years back. And if you see these, the graph, the table, there were, few virological failures in these particular trials, which are up to week 96. Anything from 1.8% to around 9% had been seen. But if you see this last column, where it have just shadowed here, there are no resistance. In these trials where people who have got virological failure, genotyping had been done, there are absolutely no mutations. So that means in patients in these clinical trials who are treatment naive, initiated on DTG-containing antiretroviral therapy, they had failed treatment failure because of adherence or one of those issues. But when they did a resistant mutation, absolutely no mutation. This is something what we have been keep seeing again and again and hearing from people and thinking that there is no integrase mutation available. But on the other hand, the last 1 year, there were case series been started getting published from North America, from Europe, and as well as from lower and middle income countries, particularly from sub-Saharan Africa, about cases of 2 cases, 3 cases of DTG mutations. But in this retrovirus conference in Croi, there is a presentation, a very nicely conducted study from Mexico on patients who had been initiated on DTG-containing therapy as ARV-naive patients, as well as patients who had switched from any other combinations, to DTG-containing therapy, which many of us have done that. So this particular analysis described various integrase resistance among people living with HIV and who experienced treatment failure after receiving, this DTG, that is a second generation integrase-based antiretroviral treatment. So what they have found, what they have done this particular analysis is, so they have done some type of trend analysis that is from between 2021 to 23 on 100 patients who had virological failure and had an amplified product where they're able to see some type of resistance mutations, which they have presented. And this is one of the largest series. The people have seen virological failure following integrase mutations, but not they've seen the mutation. They've seen a virological failure, not mutation, but they've seen and as well as seen the mutations and which they have described this. They did a population sequencing performed using a commercial kit, and they described various primary resistance mutations which is associated with this integrase inhibitor is being presented. Also, they correlated with pre-ART usages, time to failure, viral loads, and CD4, and also the association with the non-integrase resistance mutations to NRTIs or PIs or whatever they have been used along with that. I'm not going into the very much detail, but I want to show here, just to carry your message. And out of those 100 integrase resistant genotypic tests, again, this is one of the very large series at this time in 2024. Probably in a couple of years' time, people might see in thousands. So there were 79 integrase resistant associated mutations who have been identified in this analysis from Mexico. So again, you see these various mutations which are associated with integrase are 263 and Q140S and Q148H and N155H. These are some of those signature mutations which are associated with dolutegravir. Again, we have got 2 other columns. One is on patients following the first line failure. Another one, patients who have got more than 2 ART failures, either on the second line or in third line, where you can see these various resistant mutations which have been mapped. Again, this is quite a busy slide where they have shown patients who have got these R263K mutations, and along with that, what are those various current regimen they have been on, either with dolutegravir or with the bictegravir-containing therapy, and also time to failure from months, which is anything from 3 months to 26 months, and also at the time of doing genotyping, what's the viral load? If you look into the viral load, except one patient, all the other, they have a very low level viremia. Still, they're able to see these mutations. Could be because of the adherence and the CD4, and also the prior regimens, which anything from favens and NRTI to ARV-naive population to the PIs, which they have been switched or along with these, they have been, used. And also they mapped the G140S and 148H along with the other risk factors on time to failure and what are the various regimens they have used along with that. And also very interestingly in this slide, again, a very busy slide, it's very hard to put everything in very simply, where they have mapped all the non-integrase mutations which have developed along with these integrase resistance mutation. If you see this column, these are the various integrase mutations, which I described earlier. And these are the various NRT mutations. And again, if you do this 215T, it's been commonly been evolved. It clearly shows that they would have been exposed to AZT or previously in the past with the D40 failure, where again, they continuously been, seeing this. And there is L74V, which is a mutations we see following abacavir and sometimes with tenofovir. And again, M41 and 215 with AZT or in the past with the D40. And very strikingly, they're not seeing any K625R here because significant number of their patients, they're on tenofovir containing therapy, if you see on those ART regimens. So, but they're not seen that. And one thing very strikingly this group presented was, they didn't see 3TC mutation at all because all these patients were on either on FTC or 3TC. And when they had developed these integrase mutations, the 3TC mutation, M184V, which we see all the time. In fact, our group from Chennai, we have published like 15 years back. That's one of the first mutations start developing whenever we have these patients failing with the NNRTI, either with an nevirapine or efavirenz. First to develop is M184V, then subsequently TAMS and other mutations start developing. That's something it's not been seen in this. Again, patients who are also on protease inhibitors, there were few PAI mutation had been seen when they failed and developed integrase mutation, but a lot of patients, they didn't develop a PAI mutation. So that means either they're not exposed or even if they're developed, but they have been exposed to some powerful PIs like booster darunavir, which have not developed a mutation, but on the other hand, DTG has developed a mutation. So this very clearly shows that we have to be very watchful on this resistance profile. This is some of the very early report in the history of DTG resistance. That's what I wanted to spend a minute on this for you trying to understand. I think over a period of time, more and more groups start reporting this and publishing. We'll have a very clear idea about the pattern of resistance profile, not only the integrase, but also with other concob pets we have been using along with this combination. So this group, that is Ramirez, one of the world researcher in the field of resistance, presented very clearly shows that is around 20% of the people, who got a treatment failure with integrase and with resistance, and when they were amplified, they had this DTG mutation. So that means don't sit tightly that DTG will never develop a mutations. In clinical trials, we are not seen, because they're all been followed for either 1 or 2 years, and they've been done in the best standards there of improving adherence and various other peer support, but in the real life situation started giving. And very striking, as I said, they have not seen M184V, and patients, when they failed with more than 2 ART failures, they also have a mixture of integrase mutation with 140S and 148H. What will be these implications? Currently, we do not know, because there are newer integrase drugs are under development. Whether this will impact on that, this is something what we need to know, and we need to study in future. And also 263K is a mutation seen in patients with the first line failures, and also not only with the DTG, but also with the bictegravir. Again, whatever I've shown this data, they had a mixture of both dolutegravir and bictegravir. Don't think that bictegravir doesn't produce. These patients, they received 50-50 of DTG or bictegravir. Again, this 20%, have it in your mind striking. I think we may keep seeing more and more reports the next couple of years come to ending, what proportion of them will develop DTG mutations. And why it is very significant, I've been speaking to you on this particular resistance, on as part of the Croi update. That's because today, globally, 40 million people are on antivirals. And out of those, more than 90% are on combination of TLD, predominantly from generic ARVs from India. And don't forget, significant number of these persons, out of these 40 million, they switched from TLE to TLD, even without viral load monitoring. As many of you know that even in your clinics, when the DTG was launched, we all switched from TLE to TLD, or someone who's on protease inhibitors, we moved that. Now, similar in India, now we've got 1.7 million people taking antivirals, antiretrovirals. Again, similarly, we have more than 90%, even I will say even up to 98% are on DTG containing therapy. And as you know that both in the national program, as well as in many of the private centers, TLE being switched to TLD, and as well as from aracivir ritonavir combination, either with AZT or with tenofovir being moved to TLD. I'm not saying that all of you moved without viral load measurement, but significant number, especially during those COVID times. Many of the national program patients were just switched to that for various logistic reasons. And again, this I personally feel, this type of switch, because we very clearly indicated in the guidelines, do a viral load monitoring, and switch. So this probably could be a risk factor in a lower and middle income country. We need to wait for that. Now the data is coming up, from Mexico, and there are some case reports from sub-Saharan Africa. Now we need to wait for this year and the next year how this volcano is going to erupt in the form of resistance mutations, because of this strategy. I think to compare this, all this all related to resistance, to adherence. People are not adhering, they'll develop virological failure and keep repeated blips can end up in resistance mutation. I think the only way where we can do is, again, DTG is such a potent drug, high genetic barrier, as compared to nevirapine, efavirenz, and many other NNRTIs, what we have used in the past. It's such a high genetic barrier drug. But again, adherence, plays a very critical role. I think to compare this, now we have this long-acting injectable. We have been keep hearing for the last 5-6 years coming up from different data. As many of you know that cabotegravir is an analog of dolutegravir, which is an integrase inhibitor, which is developed in a way that with a half-life, which can be anything from 2 months to 4 months. And rilpivirine is a second generation NNRTI with a half-life up to 3 months, developed as an injectable. There are various trials have been done in the past, let's say 2 in the past, where we have shown every 2 months of injectable is good. And following that, this drug got FDA approval and got a registration, got into the guidelines, which is also supported by 2 other clinical trials called Atlas and Flare. So when they did these trials for the registration, they took a very clean population where patients who got a suppressed viral load and no pre-existing integrase mutations or NNRT mutations when they included in this particular trial. And they showed that it's been very effective. And following that, the product got approved by the US FDA and it been started getting used. So last year, I think this is a data which, if you have heard my talk on Croi update of last year, I had shown this data where there's a group from San Francisco, Dr. Monica Gandhi, in her clinic, in their routine clinic. What they've seen is in patients who are on antiretroviral drug, either they are suppressed or people who are not suppressed, they did a resistant testing, and people who got any integrase or rilpivirine mutation, they excluded. But all the other patients, irrespective of the viral load, they just administered rilpivirine and cabotegravir as a long-acting injectable every 2 months. And they showed the data. This is not this year Croi, last year. I just wanted to show this data and go to the next level of what they've seen this year. So in that, they found that even within a median day of 33 days last year, they showed out of the 57 who are being viremic and they received injection, 55 got suppressed. And in those people who got suppressed, all of them were maintained suppression. So this year, the same group, they followed those patients who have been taking up these long-acting injectable in the clinic in San Francisco. And they showed that out of the group up to week 48, still continue to have 81% remained get suppressed. So this is a group which had been viremic, where they went under suppression within 33 days, and week 48 they're able to maintain the suppression. This very clearly shows that even in people who are viremic, were able to suppress. But on the other hand, their population, they excluded all those who had integrase and as well as NNRTA mutation to rilpivirine. So again, whether this has been applicable in any other risky population, particularly in adolescents between 12 and 18 years, historically the data shows that their adherence is not up to 90% or above, based on different studies. Again, this is a multi-center study which included 18 global sites in the US, in sub-Saharan Africa, and as well as in Thailand, where they included patients who are virologically suppressed, and almost on 144 patients, where they moved them with whatever antiretroviral therapy to oral to have a drug levels gets boosted up with captopril and rilpivirine, then they move them to the long-acting injectable of every 2 months, the captopril and rilpivirine, with a primary outcome on safety and as well as secondary outcome on the portion of the patients who can have a virological suppression at week 48. So this is a baseline characteristics of these adolescent population. And in that, they found that 96.5% of them at week 24 continuously had virological suppression. So this is a population who got suppressed viral load with oral tablets, where they moved them to every 2 months of injectable. Because this is again a population where thought to have poor adherence over a period of time because of the adolescent, their schools and various other factors along with that. And also, when they did a PK analysis, they got enough trough levels, to suppress this virus. There is no major significant adverse events, even in this a population of adolescents where they hate to have injections, but no permanent discontinuation. So that means even the 12 to 18 years, they like this injection every 2 months. And there was one pregnancy resulting in live term birth, and there is close follow-up going on in that. But very importantly, carry home is 96.5% are able to suppress, and there is no permanent discontinuation being acceptable by this population. So our AIDS clinical trials group, ACTG group, have done this study and presented in a conference called Latitude. So here again, they recruited patients who are not adhering to antiretroviral treatment, who are being viremic, but they had no mutations to integrase or rilpivirine, and they have been hepatitis B negative. So what they did is they moved them to a standard oral treatment, improved their adherence by giving certain economic incentives, just to see that whether they're adhering to the drug, make them to suppress. Then they moved them to this long-acting injectable to one group, randomized some another group, continued the oral antiretroviral treatment. And the study up to 52 weeks. And with the primary endpoint of treatment failure, and with the key secondary endpoints with various discontinuation as well as various adverse events. But it's on quite a large number, around 434 participants. So this is a baseline characteristics in this particular group, where they also have 30% were females, and also 14% had previous injecting drug use. And if you see this very large number, when at the time of recruitment, they had 65% had a poor adherence, or they have been lost to follow-up from the program. So coming to the safety concerns, it's been very safe. A small proportion of them had severe injection site reactions, but always been well acceptable. And they all came on time, more than 93% of them. And very interestingly, this is the most important one. What they found in that is, if we just focus on the middle panel, by shadowed by this lighter orange color, but if you see the virological failure, there's a huge difference between the standard of care of oral ART versus long-acting injectables. 7% versus 25% is huge. So when they've been conducting this trial, Latitude, the Data Safety Monitoring Board, they reviewed this data, they stopped the study very early because this long-acting injectable of captopril and rilpivirine in this population is superior as compared to oral. All these zymes, they showed only non-inferiority, but here they showed a superiority for the first time in a clinical trial following this long-acting injectable. That too in a very difficult population where they have a poor adherence. But on the other hand, don't forget this is a population where they excluded who got NNRTA mutations and as well as integrase mutation. But on the other hand, very superior and powerful efficacy in terms of suppressing this virus. So this particular group concluded stating that this Latitude study with the interim data, people with HIV with adherence challenges showed fewer regimen failures and maintaining viral suppression, which has been superior as compared to standard of care oral ART. And also, very few virological failures in of course, been seen in the long-acting regimens, and as well as very few permanent treatment discontinuations. And also, they very clearly concluded that this particular regimen, will be fit for population, especially on adherence challenges. When I say adherence challenge, our patients in our clinic, they keep asking us, hey, do I have to take my tablets every day? So I think these are some of the things, not just on this population, it will be applicable for every population, even in our clinic. So following this data, this robust data by our ACTG group, IAS USA recommended this guideline, which came on March 1st and just published online in JAMA. So what they have recommended is, when supported by intensive follow-up and case management services, long-acting cabotegravir with rilpivirine may be considered for people with viremia, because all this time earlier, it was recommended only people who got a suppressed viral load. That's what the earlier FDA recommendation. So this is the first time, that is like, 12 days back, they made this recommendation, and given in the IAS USA guideline, people who got no other treatment options and people who are unable to take oral ART, and also who got a high risk of HIV disease progression, particularly less than 200 CD4, just recommend this. And also, very clearly, they said they should be susceptible to cabotegravir and rilpivirine. And also, if possible, and if needed, do other substance abuse treatment, disorders, and as well as treatment for mental illness. But again, very importantly, these guidelines they use in the IAS USA guideline been recommended in population who had a virus susceptible to cabotegravir and rilpivirine. So again, as many of you know, that in our regions, where significant number of NNRTI mutations already been floating around because of our previous usage of NNRTI and with the nevirapine as well as with efavirenz, with TLE, and in many patients continuing those failed regimen because of the lack of viral load measurements, there could be a lot of these NNRTI mutations. This is as shown by the WHO, a few years back, in lower and middle income countries, particularly in Africa and Latin America, the NNRTI mutations have gone beyond 10%, because of that only the recommendation of a non-NNRTI DTG containing therapy has been recommended. In India, still now we don't have good figures on NNRTI baseline prevalence, where we predict based on various available data anything from 5 to 10%. So it could be there. So their IAS USA guideline, where they clearly wanted to do a genotyping and do that. But again, in lower and middle income countries, it could be anything from 5 to 30% of the people can have this NNRTI mutation. So will this long-acting cabotegravir with rilpivirine work? Because rilpivirine is an NNRTI, where some of the mutations following nevirapine and efavirenz will also jeopardize rilpivirine. To study this very nice study, very interesting study, which was carried out in Africa, in Uganda, in Zambia, and as well as in Zimbabwe. So it's a trial called CARE study. So what they did in that is they used this long-acting cabotegravir and rilpivirine in patients who have got suppressed viral load, where they did not do any genotyping. So these are the people who are on antiretroviral therapy. Either they were on TLD, or probably they would have been used TLE in the past, where they have been switched to TLD even without a viral load. This is something similar like our practice has been used in the sub-Saharan region in their programs, where they do not have their resistance profile. But they excluded people with the hepatitis B because you need tenofovir and lamivudine or emtricitabine. Also, what they did was they drew sample and stored for future resistant testing. They didn't do it at the real time, but they started a study. So it is a randomized study where one arm continued the same whatever ART regimen they were on, and the randomized group, other group, they received, some of them they received oral cabotegravir rilpivirine as per the standard guideline, but on the other hand, majority of them directly went into the cabotegravir long-acting rilpivirine, which is now recommended as part of the guideline. The primary endpoint of what proportion of the people with less than 50 copies at week 48 with the snapshot FT analysis, and with the secondary endpoints of proportion of people with more than 50 copies with virological failure and safety and tolerability. And also, very interestingly, they also introduced a treatment satisfaction questionnaire that is very important for patients' acceptability. So this is a study which was carried out in Uganda. Okay, your excuse is in Kenya, not in Zimbabwe, and as well as in South Africa. So these are the three countries who participated in this trial. It's quite a large number of patients been randomized, almost 512. So randomized, and very interestingly, they're able to return almost 99% of them at the week 48. That's something very interesting. to show you good data from this clinical trial. So this is a baseline characteristics, what they have seen, in these patient population. And if you see these shadowed orange shadowed numbers, so these are the data which was generated not in real time, but from the stored specimens. If we see this, what will be relevant, particularly for India and for our population, is these RPV mutations. What they've seen in this is at baseline, almost around 13.5% of them have this rilpivirine mutation, which is an NNRT mutation. So they did not use this. They did not do these measurements at the baseline when they randomize a patient. So they randomize everybody irrespective of the mutations. But they did this, at the end of the trial because of the logistic reasons, because they couldn't do that. And also another thing to answer the question, in a public health setting, hey, you don't have a genotyping, can I use this drug, to get this maximum value out of this? So they use archived pro-viral DNA analysis at the study conclusion. Very interestingly, surprisingly, nobody ever believed. They showed this data at the oral presentation in Croi and found that irrespective of the mutations, they did not know even whether they had mutation or not because they randomized people irrespective of their baseline mutation. Almost the same between oral tablet and this long-acting capsule. Almost 96% of them continued this virological suppression. And there is no major, there are one or two treatment failure, but they did not find any, major resistance mutations to report. So this is something very interesting, but there are several questions on this. Now the group is going back and studying what proportion of them who had these baseline rilpivirine mutations had this suppression versus people who did not have. I think this type of data, they have not released it. I think we need to wait for this. This is a very important data for lower and middle income country, particularly for India, where NNRT had been used like water in our patients and where significant switches have happened from TLE to TLD. And when they looked into those safety endpoints, which has been very safe, and there is no significant discontinuation happened or very grade 4 toxicities being seen. And very importantly, especially for our patients, they did administered a HIV treatment satisfaction questionnaire, which was well validated by WHO and a lot of other bodies. And they did at the baseline and as well as at week 48, because the baseline till that time they were on oral tablets as part of their regular regimens. And at week 48, they had received these long-acting injections, for a year. And they found that it is significantly, they had a better, treatment satisfaction with this injectable. So this is something very important because our patient loved that. And they're interested. They come back and have this injection shot as compared to this oral tablet, which is hugely been, significant. So this care study group, which was carried out for the first time, this type of randomized trial in a lower and middle income country where a lot of NNRT mutations already been circulating based on the WHO reports, they found very high virological suppression irrespective of the mutations. But now more and more data, we need to look for it. And again, no significant adverse events. And the group also showed that the participants who received this injection, they are greatly been satisfied over a period of these 48 weeks. And they concluded a study showing that it's been safe and tolerable and effective, even in this population where they can have mutation. But again, the data just presented. Now they are being digging up the data. So we need to wait more and more for that because this will be very relevant, particularly for India when you are going to use this drug. Right now, this long-acting drug is being currently approved by US FDA. It's been used in North America as well as in Europe and as well as in some of the other lower and middle income countries, particularly Malaysia and some of the other regions. It's been available, not available in India. Of course, one day soon, our Indian generic manufacturers will bring to us. At that time, the question, they'll be asking us is, hey, will you use in your patient? Because it is called a rilpivirine, you already have a mutation. Now, I showed the care study. We need to closely monitor these groups, other further follow-up data, and based on that, we'll be able to make enough assumptions and conclusions on how this drug can be used in our population. Also, it's been recommended in the IAS USA guideline, but not in WHO guideline. So immediately don't jump into that. We are looking at this data very carefully, and as well as the pattern of resistance profile. So probably there will be some recommendation from WHO, not immediately, in the next 6 months to a year's time, what will be this role of this capital rilpivirine in lower and middle income country where a lot of these NNRTI failures had been seen or switches had happened from TLE to TLD. Now, moving to other future HIV treatment, again, some exciting data being presented. So these are all, what I showed is all injectable, where there's a logistic issue, where you need a needle, you need a trained nurse or a trained, provider, and you need a private space because this injectable has to be given in the buttocks where, again, and also you need to safely discard these needles and so many other logistic things, especially in visit clinics, particularly in the national program where a large number of patients, seek care. So can we have certain things very easy to swallow, like a oral pill, which are long-acting? So there is a very nice and very interesting presentations being done at this Croi, which is a phase 2 trial of oral weekly islatravir and lenacapavir. If you have listened to my talks in the past on the Croi or ARV updates, I had talked about this molecule, about the early drug development. Islatravir is a drug, again, which is a nucleotide translocation inhibitor, and the lenacapavir is a maturation inhibitor. These are all new class of drugs. Even the other class of drugs fails, it can work on that. So it is again a translocation inhibitor. Lenacapavir is a capsid inhibitor, which is more potent. And they have earlier phase 1 studies that have been published showing that, it's been very potent. And it's been developed as a long-acting injectable, and the data had been shown. It's the first time they're showing some of those oral weekly medications. Earlier, all been shown was all been injectables. So again, islatravir is a drug in the past, when they're given as a long-acting injectable, had shown some decline in CD4 and as well as in the absolute lymphocyte count. And because of that, this drug was parked for some time by the FDA, and now it has been found that that decline in CD4 is dose dependent, and they developed a dose of 2 milligrams islatravir, and they found that in subsequent study did not reduce the CD4. Now the company has been moved forward with these 2 milligram dosages. But now the group also have developed this as a oral tablet rather than long-acting injectable. And in this particular study, where they combined this oral islatravir with 2 milligrams with the lenacapavir, which is a 300 milligrams administered once weekly in virologically suppressed people living with HIV, just to show whether this can maintain the virological suppression. So this is the design of the study. This is a phase 2 trial. They recruited patients, little more than 100, who received oral therapy, everyday treatment, and who got a suppressed viral load of less than 50 copies and CD4 more than 350. And no hepatitis B, because both these drugs do not have a hepatitis B activity. They randomized into 2 groups. One group received the same standard of care of TAF, emtricitabine, and bictegravir, and the randomized group received the test regimens of islatravir, which is the 2 milligrams with the lenacapavir 300 milligrams, and it has been weekly ones, very exciting. And the study they followed up to 48 weeks, and also there was an extension period being planned. With the primary endpoint of proportion of the participants with viral load of more than 50 copies at week 24 with the FDA snapshot algorithm, and also with the secondary endpoints on safety and PK levels, and also with the CD4 changes, because this islatravir was parked earlier because of the declining CD4. So that was also been used one of those secondary endpoint. So this is a baseline characteristics. If you see between the 2 groups, there is no major significant changes. Almost around 20% of the women also been recruited in this. Of course, pregnant women been excluded. So this is in the adult population. So children not been included, and it's mostly whites and blacks and very few Asian being recruited in this particular trial. If you see this virological suppression at week 24 in the FDA snapshot analysis. So this blue color one is the one with the 94% suppression. It's almost similar like everyday oral tablet. So that means weekly oral islatravir plus lenacapavir maintained virological suppression of less than 50 copies at week 24 as compared to everyday oral medications. And in this, there is one individual with islatravir and lenacapavir who had more than 50 copies at week 24. And the investigator did not change the medicines, but the patient again got resuppressed at week 38 without any treatment change. and there are adequate drug levels there, and there is no resistance had been detected. This is a particular individual who had, viral load non-suppressed at week 24, it was at 64 copies, got suppressed at 50 copies. So there could be some adherence issue because at screening they've seen 50. At day one, they've seen 251 copies. Sends, not fully suppressed, but got suppressed at less than 50 copies. So it is not due to any, we won't call it as a treatment failure, and there is no drug resistance. Very clearly shows that very strikingly, and this oral weekly lateral lenacapavir, new class of drug, being suppressing virus so effectively, similar like everyday oral tablets. And if we look into those adverse events profile, and which has been mapped on various, because it's a oral tablet, there is no injecting site reactions. We also looked into the various other laboratory abnormalities, starting from creatinine to various other liver parameters and other metabolic parameters. There is no significant abnormalities to discontinue anyone except one person who developed an acute hepatitis B infection. And very importantly, this is very important, especially for the regulators, because, as I said earlier, US FDA popped these drugs Latravir in the past when they use as higher dosages because it was causing decline in CD4 cell count despite virological suppression. But here, this CD4 change and the absolute lymphocyte count is one of those secondary endpoints. If you see this from day 1 to week 24, there is no changes in decline. In terms of these numbers, you're able to, see this, and including this, the absolute lymphocyte count, there is no, changes have been, noted. So this is very important, this particularly for the regulators and as well as people who had some issues on this Latravir. This did not cause any CD4 decline and as well as lymphocyte count, changes at week 24. So the investigators of this particular trial, they concluded, people with HIV who are virologically suppressed, a combination of Latravir at 2 milligram, lenacapavir with 300 milligram, as a weekly oral, maintained virological suppression, similar like everyday oral tablet, was well tolerated, and no significant adverse events, and there is no significant changes in the CD4 decline or in lymphocyte decline. The study is ongoing because it's only week 24. We need a little more larger data to take it up for guidelines. This again is very much relevant, particularly for our country, giving injectable. There was a lot of logistics, especially people who practice in an office setup, giving this long-acting injectable, whether this weekly oral tablet can be an option. And again, this is something what we are looking for. I'm sure one day, if it is going to be approved, our Indian generic companies can make it even as a single pill, just people take it just weekly, one tablet. Again, wait for this data. Now, moving to those other interesting compounds which are being presented at this conference is on oral weekly, the other newer molecules. So this is again a drug developed by Gilead called GS1720, which is a newer integrase inhibitor. They think that it is a newer generation of integrase, much more potent than Bictegravir and Dolutegravir. They've shown the phase 1A study, and they have shown the dose ranging studies from 30 milligrams to 900 milligrams. And they've shown that even within 10 days, they're able to do significant virological suppression. So this is again as a monotherapy. So that means this oral weekly tablet with a newer integrase inhibitor is so potent as compared to historical, placebo. Again, this is something what we need to wait for more and more data. So now it has been promising, and now the company has decided to move forward with further development of this molecule. And what about other oral weekly treatment? This is again another newer nucleoside has a reverse transcriptase translocation inhibitors, similar like Latravir, but little smaller change in their structure of the molecule. And also they have already done some in-house studies and they found that it won't cause any CD4 decline. And now they have shown this phase 1 data on the dose ranging study on the mean decline in viral RNA. We've shown that by day 7, so potent, and they're able to suppress the virus. Again, this is something which I personally feel that drug might move forward. This is a oral weekly HIV treatment. So it has been, fantastic that now we have a weekly oral Latravir is moving forward to phase 3 trials. And we have these oral weekly GS1720 going to be come forward, and it's a new class of drug with a newer integrase, and also with this nucleotide reverse transcriptase translocation inhibitor, which will also work on patients who have got tenofovir failure, backcover failure, lamivudine failure, and azectic failure, because it'll be hypersusceptible to those mutations developed by other NRTs. This is something exciting molecule. We have to wait for it in future as a oral tablet weekly as a long acting. There are a lot of discussions on broadly neutralizing antibodies in HIV. I know many of you may not be interested to hear this lecture. Hence, there are 4 good studies been presented. So I'm not going to the details because this is a long way to go. These are all in pipeline. We are nowhere near that. I just put all those 4 studies which was presented. A study called Banner, so where they use neutralizing antibodies is on CD4 and 62 patients on phase 2, where they found good antiviral effect, and also it has got a long-acting potential up to 6 months. And our the AIDS clinical trials group have done these 3 monoclonal antibodies called tribasic antibodies, and along with the long-acting cabotegravir, on 71 study participants on a phase 2 trial, also have shown, significant virological suppressions, which many of those molecules can be developed anything from every 2 months to, 6 months as an injectable. So this particular trial is called with lenacapavir and 2 other neutralizing antibodies, one called TAB and SWAB, and it's been previously presented in the previous Croi on a data of up to 12 weeks. Now they have week 26 data have shown that they're able to maintain virological suppression, but also there is some resistance can also be developed to one of those neutralizing antibodies, but not to lenacapavir. So more work is currently happening on this, but again, this can be developed for as a every 6-month shot. That means somebody who's suppressed with a oral or any other antiviral drug, you can give every 6 months a shot where they maintain virological suppression. Again, this in the phase 1B, we need to wait for more and more data. There is also another study presented which called with the PGT121 and also with another monoclonal broadly neutralizing antibody. And this group have earlier shown a phase 1 data, now phase 2, where they've shown a drug which can also be being developed up to every 6 months as an injectable, which will have a huge potential as a long acting. Again, these are all work in progress. And these are all Croi's conference where they showed all this interesting data, but it's a long way to go, move to those as part of those guidelines. So what are those key take-home points from my long-acting antiretroviral treatment presentation? Is in the CARE study from Sub-Saharan Africa, where they've shown even if they have resistant mutations, this long-acting cabotegravir works, but we need to wait more and more from them. The most choice study on this adolescent population where they're able to get the viral suppression maintained and good acceptance in 12 to 18 years. Latitude is a study in a very difficult population where they're able to maintain even superiority they're able to show, and following those IAS USA guideline made a guidance on that. And also in a chronic population in San Francisco, they're able to see in patients who've been viremic giving this long-acting cabotegravir maintaining virological suppression at week 48. And with some of those potential future treatment on the phase 2 study of oral slatravir and lenacapavir weekly once, they're able to show good efficacy and no changes in the CD4 decline. And with the newer drugs on phase studies with integrase GS1720 and as well as with a translocation inhibitor on MK8527 demonstrated good viral response, we need to wait for more and more phase 1b2 data to move to the next line of therapy. And also the BNAbs, what's been studied currently has been very promising, but still under very active investigation, still not ready for prime time. So we need to wait for more and more data on that. I want to end my talk because will be running out of time. I'll end my talk just to show 2 comorbidity. I'll not go into the detail. So as we know that REPRIEVE is a study which was carried out a few years back, which is, personally, I was also one of the key investigators of this trial. We recruited very large number of study participants from Chennai, where we used statins, pitavastatin, patients who are virologically suppressed against a placebo. And last year, we showed that there is 35% reduction in various major cardiovascular events when they are on these statins. And it's been presented last year. as well as we, publish this now and become part of the guidelines in the DHSS guideline as well as in the European guidelines. So in this particular conference, our group further studied that how the statins prevented all these cardiovascular events. We did some proteomic analysis based on those specimens being stored, and variety of different proteins had been studied both in the placebo group as well as group in the statin. And it's been found that there is one particular protein called procollagen C entopeptidase enhancer. Now we call it in short term called PICOL-C, which has been increase in expression had been seen, in this particular, study, which is a very important enzyme, which can cause, increase in this atheromatous plaque, which is one of those reasons thought to be causing this cardiovascular event. So this particular pitavastatin has an impact, particularly on that. It causes doubling of this expression on this, and which has been associated with almost 31% decline in this atheromatous plaque, which is called non-calcified plaque volume, being seen. So this is something what was never known in the past. Everybody used to think that when you give statins, it reduces LDL cholesterol. As a result, the people won't develop a cardiovascular. So in this particular reprieve, which is carried out in HIV-infected people, we found 36% reduction in cardiovascular event. And we thought it was due to the traditional way of reducing the LDL, but that was not the reason. It is because it causes this particular expression of this protein, which has resulted in this calculate volume reduction, and because of that, there was a thing rather than this cholesterol level. So this is something what is never known. No more going to happen on this particular study, as well as future usage of statin, not only in HIV-infected people but also in the general population. Also, I'm going to wind up soon showing that there is another comorbid condition we see in our patient population when they're taking antiretroviral on the long run. Is metabolic associated slim liver disease. Again, there are no specific drug in the past for that, but of late there has been studies using this semaglutide, which has been GLP-1 receptor agonist, which is a very famous drug now among the diabetologists. Which also have shown reduced hepatic fat, particularly with the type 2 diabetic patients. So this particular trial on phase 2B was presented at this Croi using this molecule on semaglutide. And they have done, using MRI, they quantified intrahepatic triglyceride content just to see whether it will have any impact on this particular disease progression. So they recruited around 50-odd patients, who fit into this of more than 95 centimeters of waist circumference. They used first weekly 0.5 milligrams subcutaneous semaglutide, then they moved them to 0.5 weekly. Then after 4 weeks, it was being given 1 milligram, and they followed up to, week 24. And this is a baseline characteristics of this particular trial, and with the primary outcome of changing the intrahepatic triglyceride, content. This is something what they wanted to look into that as part of giving this semaglutide. So what's been seen in this particular trial is there is a huge reduction accompanied by significant improvement in weight, BMI, waist circumference, and glucose, A1C, and as well as triglycerides. And there was a mean weight loss of 7.8 kilograms. It's been seen in this trial. It's something everybody would love to see this data, and greater loss among women, and especially more than 40 years, and was hugely significant of this intrahepatic triglyceride content. And this analysis also, they found that the effects of this semaglutide on the muscle structure as well as function, which has resulted in the loss of psoas muscle volume without change in the muscle fat. That is something initially they found is a cause of concern, but nothing's been significant. And also in HIV-associated lipohypertrophy with no diabetes mellitus, this semaglutide resulted in significant decreases in abdominal visceral adipose tissue, subcutaneous adipose tissue, and total adipose tissue, trunk fat, limb fat, total body weight, lean body mass, and weight. So this is another molecule probably, can be used in our patient population who got this condition. The key points from these comorbidities, what has been presented is these statins, what been used, it didn't do a traditional of reducing LDL and causing decreasing in the cardiovascular, but on the other hand, he expressed out this particular protein, and which resulted in this reduction in cardiovascular events. And of course, in the slim liver study, where usage of semaglutide was associated with significant reductions in this intrahepatic triglyceride, content. I'm going to conclude by stating that our future strategies, when someone is on oral therapy, will be moved towards how we can use some of the newer agents which I've shown when it comes to the market, and as well as some of the long-acting, which we have some interesting data coming up to use these in lower and middle-income countries. Whatever newer drugs coming up, still HIV persists. It's an incurable disease. It's a lifelong treatment. Captive rilpivirine, is moving forward. There are a lot of cause of concern, particularly rilpivirine. Now it's been moving forward. Weekly oral ARVs, what I said on Nacam's is very promising. Wait for it. Combination approaches with BNAPs are under development, but not ready yet. But on the other hand, preventing NCDs, which is a major problem in our patient population who live 10 years, 20 years with the antiretroviral therapy, will be a future question. Now, with several interventional studies are underway, and some of the molecules which I've said will make it as part of our guideline, especially people who are on antiretroviral therapy on a long run to prevent their comorbid conditions. So I also like to thank some of our friends, who generously shared the slides, because these are all very new data, unpublished data just presented, and the conference just happened last week. So, I was able to get some of those data out, with their permission and to show here. And I'd like to thank them. Otherwise, I would not have completed this presentation. Thank you again for this opportunity. Happy to take any type of questions. Thank you so much.
Okay, thank you, Dr. Kumaraswamy sir. It was an excellent presentation. You have brought in the latest updates on Croi. As I understand, this conference has happened last week. So these are the fresh from the oven, I can say. So thank you, sir, very much. And I request dear doctors, if there are any questions, please put on the chat box. Some of the questions we like to ask that if there is a DTG failure, sir, what would be the next option?
So I think first we have to prove that whether it's a DTG failure, So we have seen here in the past, I showed a meta-analysis where they had a viremia, but when they did their resistance mutations, they're not failing. So we have to prove that there is a resistance mutation. So right now, if they have developed a resistance mutation, I've shown some data. I think we have to do a genotyping to find out what are those possible options. So right now, booster Darnaver seems to be very potent. They're not seeing any mutation along with their DTG failure. And we may have to recycle one of those NRTIs, preferably a tenofovir, because tenofovir, lamivudine, that mutation had not been seen in this particular data which has been presented. So probably the option of tenofovir, lamivudine, or emtricitabine, along with the booster Darnaver, could be a choice when someone who got a failed.
Okay. Sir, I'd like to ask your views on this long-acting anti-HIV preparation, the injectables. I think many of them will come up. I think internationally also they have been launched. So your views on this injectable long-acting preparation, sir?
I think that's a data which I presented, the one which is approved for use in North America and Europe by FDA, and as well as now some of the guidelines is long-acting cabotegravir and rilpivirine every 2 months. Initial recommendation was only in people who have got suppressed viral load, who should not have DTG mutations, integrase mutations, or rilpivirine mutation. But now they also been recommending in people who have been viremic, following the data from the Latitude study, but still they put a caveat that they should not have rilpivirine mutation. So that's a current recommendation. But I also showed this data from the CARE study from Africa, which was carried out in Uganda, Kenya, and as well as in South Africa, where almost they have 13% NNRT baseline mutation till the drug works. But again, the preliminary data they presented, we have to wait more for it. I think to your question, what will be implication in India? I think that particular trial data will have a huge implication for India, because our NNRT mutations, I personally feel, could be even more than 10% or 15%, because we had used and they continued the failed regimen for a very large number of weeks and months because of the lack of viral load monitoring. So I think that data will tell us what could be. But on the other hand, some of the other long-acting newer therapies coming up with the lenacapavir, which is both as an injectable of every 6 months, which have been shown in the last year, and now as a oral tablet weekly, and latravir, which is weekly oral tablet. These are all very promising, because whatever mutation we have doesn't matter, because here this will work. But it won't work with the hepatitis B. We need to study this in TB population, pregnant population. So we have a long way as a clinical trialist to answer those unanswered questions. And also some of the newer therapies. Now, every new drug which is coming up, these are all not just everyday tablets. They're all long-acting. Either these long-acting oral tablets or long-acting, injectables. So we are going to have exciting, antiretroviral therapeutics as compared to a lot of other diseases where they don't have this amount of newer stuff coming up.
Thanks, sir. Thanks, sir. So the injectable is a boon, so that people may not find out that this patient has got HIV. So just taking this injectable tablet will benefit for the patients. And also, sir, you have also shared on this oral long-acting preparations. So your views on these orals also? Yeah.
Yeah, I think this injectable is always have a logistic in that, and also the cost concern. The cost, even if you are going to develop generically, I'm sure one day soon your company is going to develop this. So it's not going to be the comparable cost of the current oral tablets, because of the technology involved, and as well as the storage issues, because rilpivirine have to be refrigerated, and the needles what you're going to use. And also you need a trained personnel at home, at a clinic to do this, and the private space, and all those logistic issues. This weekly oral will be a attracting boon for lower and middle income countries.
Okay. There is a question from Dr. Partha Sarathi. So instead, in clinical studies, we study efficacy of a drug only a few weeks or months. So what would be the long-term implications of such data?
So I think we always start with the small. When we do clinical trial, we first show 7-day. Hey, what this drug is going to do in suppress. So we showed some of the new molecules. Then at the clinical trial, we show 12 weeks. The minute when you have 12 weeks, we all excited. Oh, it's going to be some sort of things coming up. Then we develop a trials to week 24, follow them 48. Now this is a way where we do all those drug developmental studies. And again, if you don't see anything fruit out of those the first 12 weeks or 24 weeks, we will not go further forward. So I think this is a long way to go in these antiretroviral drug developments, including DTG. I think, I remember when these drugs are all being developed, but it took a lot of time, over a period of years and get it into the market. Similarly, I think we had to wait for it. I think this is a CME webinar with the Croi update. I think for our clinicians know that we have a lot of exciting molecules going to come up in pipeline, and they are going to be very exciting, different way of mechanism of action, maybe highly potent and long acting.
So there is only one question. So if a patient is failing on DTG, can he be shifted to bictegravir?
Definitely, the answer is no.
Okay.
Because both DTG and bictegravir share the same mutations. I think in my slides I've shown from the data, how from the Mexican data that how this bictegravir and DTG almost are similar. So you can't change. If DTG is failed with the mutations, and bictegravir will be done. But on the other hand, someone fails raltegravir, you have to look into those mutations. So DTG still can work. But on the other hand, there are studies have shown previous usage of raltegravir is a risk factor for DTG failure.
Yeah, I think so. These were the questions. So if Mr. Balaji sir, if there are no more questions, can we now go to the closing?
Yeah. So thank you, Dr. Kumar Swami. Basically, one observation that I would like to present here is that much as the studies of injectable cabotegravir and rilpivirine are encouraging, we as generic manufacturers who are catering to more than, I would say, 80% of the HIV population worldwide, we still do not have access to the licenses for the combination therapy. Because whatever license has been given till now, it's been only for the PrEP indication, not for the treatment. So that is still, we don't know when it will come and how it will come. And then, of course, developing the injectable cabotegravir and injectable rilpivirine is going to be a long drawn affair. It's not something that's going to happen overnight, or these injectables have its own challenges. I believe even the bioequivalent studies itself is going to take 1 year for these injectables. So apart from the developmental work, then the injectables. So we don't know. We do not have access at this point of time. We do not have access to even the licenses per se, which was not the case when we were earlier dealing with other products or other innovators' products. So this is something that is still we don't know what is the kind of a timeline that it is that we are working on. It's not. I'm not talking of only India, but even for the access countries, the licenses are not there. Although the trials have been done in access countries and in African countries, where the HIV burden is quite a bit. So the injectable cabotegravir and injectable rilpivirine combination is still a far way to go.
Yep.
Now, when it comes to the other interesting thing was the once weekly oral options, but that again I can see that it is in phase 1 trials, whether it is the GS option or the MK8527 option. So that again is still going to be some distance away before it is developed and the BE studies are done, and then the product is available for the access countries. So in this interim period, there seems to be a lot of talk about dolutegravir resistance and all that, and definitely at the clinician level, the people are going to start pushing panic buttons about dolutegravir resistance. So what is your take-home message on this?
I think my take-home message is currently the best weapon we have is the TLD. Use it well, but on the other hand, make sure that patient adhere to that. Why they are failing because of adherence. I think improving the adherence in every visit, using external support is something what we have seen in all the regimens in the past. I think that's the most important one. So in the clinical trial, we have seen it caused viremic because of adherence, but no mutations. But if they keep on doing that, it can end up in a resistance mutation, even if it is high genetic variant. Not easy, but it can happen. But the other risk factors here for developing the integrase mutation is because of the pattern of the switch had been done in the lower and middle income countries. When people who are on NNRTA with the nevirapine or efavirenz suddenly switched to BTG containing therapy without the viral load monitoring. So they had a big bunch of mutations and everything. We do not know whether that could be one of the factor or not. These are some of those work in progress. And again, what are those integrase mutations which will impact the complete treatment failure? Whether one particular mutation or a mixture of mutations. I think these are some of the things which we are very interested, and we have a working group on resistance at the WHO level. We are very seriously looking at that to feed data, for the guideline. So I think right now, to your question, I think use our current drugs very well, improve the adherence, keep doing viral load. Right now, it's been recommended every year. So in the guidelines, if you have an opportunity, do it every 6 months, because that itself will tell us how they have been adhering to this, if they have been viremic. Now, viral loads are getting cheaper. I think that's something what we have to invest to find, improve adherence. If they are virally viremic, improve the adherence, before they fail with mutations. And their newer drugs will come. I'm very optimistic. Many years back, I spoke about dolutegravir, which is nowhere in resource-limited settings. And now it is like a water everywhere. Everywhere I go in the world is TLD. 40 million people, globally on Indian-made everywhere. I think as you brought up very important points on these licenses and the complexities. I think we have to work on that, because we should not say that that's an obstacle and barrier. We have to work on a way that how we can get these molecules into lower and middle income countries to help our patients. I'm very optimistic one day, Mr. Balaji, you'll launch all these molecules, from your company.
Yes, we are quite excited about the science that is brewing behind these molecules. And we are looking forward to laying our hands on these licenses and start getting things rolling. So we will always be there in the forefront in bringing out these new generation molecules. But until they actually see the light of the day, I think physicians should not press the panic buttons and say, what's next? What's next? There are a lot of things that will happen, maybe once weekly, then once in 6 months, whether it is oral, whether it is injectable. All these things will happen certainly because the science is evolving, and so also in HIV.
Yep.
But having said that, Doctor, was there any discussion about vaccine development for HIV?
There are separate sessions and studies going on. Nothing very interesting or promising to report here. But on the other hand, there are a lot of long-acting injectables, like as a prevention, as a prep. Now, that's like a vaccine. For example, if the lenacapavir comes up every 6 months, somebody has got, that protects. And they've been talking about using doxycycline as a prep preventing, STI. There are a lot of other things that are all being there. This HIV vaccine science, still now what they are currently been developing is these neutralizing antibodies, which are now under development for treatment, which some of them I showed here. And now that is also been reframed as a vaccine, but it's not just a one shot. Maybe like you may have to have multiple shots in a year, like a vaccine. This is something what's been under development. So it's a long way to go. So there is nothing interesting to report here.
So thank you, Doctor. And if there are no other questions, we have this. We continue to bring in this kind of webinars to our population, the doctors, the pharmacists, and all of them who have been following us, and all those people who couldn't make it to Croi. Your insights are very interesting, encouraging, and especially your interpretation of these in terms of its usage in the access countries like in India, in Africa, and so on, its relevance with respect to current standard of care, the advantages, disadvantages, and all that. I'm sure it is very interesting times ahead. We are keeping our eyes and ears open, and we will have further updates going in. In fact, this time we will also be present with our stall at the AIDS conference in Munich in the month of July. And we would then once again have a similar session for updates from the AIDS conference. But until then, thank you very much for your evening, and for all those who have joined from various parts of not only India but all over the world. Have a nice evening, and good luck to all of you. Any closing remarks, Doctor? Dr. Ketan?
Yeah, so on behalf of MQ Pharmaceuticals, sir, we thank you for these wonderful and illuminating updates. And thank you so much for your precious time. And I also wish to thank the audience for attending and encouraging us to give you a lot of updates on HIV by expert panelists. So this webinar is brought to you by Conquer HIV division of MQ. So thank you very much, and I wish Dr. Kumaraswamy sir a great evening ahead, and also for the audience who has joined us. Thank you very much.
Thank you so much.
Thank you.
Bye-bye. Bye.